Greetings. My name is Greg Sund. I'd like to thank the organizers of this conference for inviting me to share a bit about my experience with pain management in Burundi and in Kenya. I have nothing to disclose other than the fact that I am not a pain management specialist, nor am I an academic. I'm just an anesthesiologist who found himself working in sub-Saharan Africa and wanted to do something about the pain management practices that I observed in the hospitals I was working at. These are my learning objectives. So to start with, I want you to imagine this patient, Mr. Smith. Now, Mr. Smith was walking down the road minding his own business when a careless driver happened to swerve and hit him, breaking his femur and his humerus and some ribs. Now, it's possible Mr. Smith lives in a high-resource setting, and within 10 to 15 minutes, he'll be taken by ambulance to an emergency department like this one with ample staff who are highly trained, efficient systems, and a pharmacy that stocks every analgesic known to man. And within a few minutes, he'll have an IV and be pumped so full of Dilaudid he'll forget all about his injuries. But it is just as likely that Mr. Smith lives in a low-resource setting. And perhaps over the course of hours, maybe even days, he will eventually make his way to an emergency department like this one, where there's one nurse who may or may not be on strike that day. The family actually has to walk to the nearest pharmacy to purchase an IV and a bag of normal saline. And this emergency department stocks no analgesics, and the hospital just happens to be out of morphine altogether. The only thing that determines which experience Mr. Smith has is where he happened to be born, nothing else. So in 2014, my family and I moved to Kijabe, Burundi, which is about a 3-hour drive from the capital city, Bujumbura, to work at a rural district hospital. As background, I think you all know by now that the WHO estimates that 5.5 billion people do not have access to adequate treatments for moderate to severe pain, and sadly, the majority of these patients live in low-resource settings. Data on pain and pain management practices is quite limited, and so I think the first step we need to take is to gather more data to identify what is the scope of this problem currently, what are current pain management practices in these settings, and what are the obstacles that are preventing healthcare providers from adequately addressing people's pain. This is a meta-analysis from Anesthesia and Analgesia in 2016 looking at the global burden of pain in low and middle income countries. And the authors found that 34% of adults had some sort of chronic pain condition without a clear etiology. Obviously, as an anesthesiologist, my interest in pain management is focused more in the perioperative period, for which data is also quite limited. However, there was a very recent article in Anaesthesia looking at the implementation of a perioperative registry in Ethiopia. While this study looked at the registry of multiple perioperative data points, one point they included was the evaluation of pain, both in the PACU and at 48 hours after surgery. And what they found was that 31% of patients did have their postoperative pain assessed using the visual analog scale. However, from the time of discharge from the PACU to 48 hours post-op, only 3% had their pain assessed. So I believe we all know by now that significant barriers exist to providing appropriate and adequate pain management for patients, especially in more rural settings. These limitations include, but are not limited to, staffing limitations, and that can be not just the number of staff present, but the amount of time that those staff have to address to pain management. Unfortunately, pain control, which is often viewed as a patient's right in high-resource settings, is seen as more of a luxury in low-resource settings. There are also medication and training limitations. The creation of a multimodal analgesic plan requires the pharmacy to have a wide range of analgesics, as well as staff, both nurses and doctors, who are familiar with how to prescribe and administer those medications. And finally, there are also financial limitations. In very low resource settings, like the hospital I worked at in Burundi, many patients simply could not afford to pay for prescribed analgesics. On the bottom, you'll see the ratio of palliative care providers to the population. In Kenya, this is 1 to every 4 million people. In Burundi, I can tell you, sadly, there are no palliative care providers currently. So, in Burundi, we started by asking ourselves three questions. What resources do we have available to address this problem of postoperative pain? What interventions would be feasible and sustainable? And could the impact of these interventions be measured? Now, quality improvement work in a setting like this is quite challenging, and collecting data about that work is even harder. This was a visiting doctor from the US who came to our hospital wanting to collect some data, and he asked to be pointed to the medical records department, and we brought him here. So as you can imagine, finding the data that you're looking for in that pile of records probably feels a lot like trying to unwedge a massive container with that tiny excavator. I do owe a huge debt of gratitude to Dr. Wayne Morris, who came to Burundi to teach a 2-day workshop entitled Essential Pain Management, which laid the groundwork for what we went on to do at our hospital in Burundi. Now, by the way, Wayne and I did not coordinate our outfits on this day. We both just happened to have fabulous fashion sense. So Dr. Wayne and colleagues created this workshop, which has now been taught in over 60 countries. And this workshop gives healthcare providers some basic tools in the recognition, assessment, and treatment of pain. And this workshop has also been translated into French for use in Francophone countries like Burundi. We published the results of what we found in the South African Journal of Anesthesia and Analgesia. But before we could implement this service, we needed a tool to assess the pain that our patients would understand. Thankfully, Dr. Olufalabi presented his work from Rwanda at the last All Africa Anesthesia Congress in Marrakesh. And after his talk, I asked him if I could possibly borrow this pain scale, which he presented, which had been translated into Kinyarwanda, which is very similar to Kirundi, the language spoken in Burundi. And thankfully, he agreed, and we had this scale printed and laminated for use on our daily pain rounds. On the left, you can see our chief anesthetist in Burundi teaching the Essential Pain Management Workshop. On the right, you'll find the logbook that we used to collect data on all of our postoperative patients for a period of 3 months before and after we taught this course and began our daily pain rounds. This intervention was performed by myself, along with medical students who were rotating with me on anesthesia and critical care. And here's the results of what we found. We did find that there was a significant reduction in pain scores on postoperative day 1 and also on postoperative day 2. We also found that the time to first ambulation after surgery decreased by just over 10 hours. And regarding the utilization of analgesics, we found significant increases in the use of oral tramadol, as well as IV morphine, which was almost never given before this intervention, and even increases in oral paracetamol. We expected that there would be significant obstacles to this intervention, and so we wanted to examine what obstacles we encountered in adhering to the WHO analgesic ladder based on patients' reported pain scores. And I was actually surprised that only 24.5% of our patients encountered some obstacle. Those were sometimes patient-related, the most common being patients' inability to pay for prescribed analgesics, sometimes provider-related, the most common being the surgical team simply forgetting to prescribe analgesics postoperatively, and sometimes pharmacy-related, the most common being medications being out of stock, sometimes for days, sometimes for weeks at a time. In August of last year, my family and I relocated to Kijabe, Kenya, where I currently live and work. Obviously, Kenya is much different than Burundi, and the hospital I work at now is significantly more developed than the hospital I worked at in Burundi. And thankfully, as it turned out, similar work was already underway at Kijabe thanks to the efforts of Steve Muchai and Dr. Matt Kynes. So the team at Kijabe in 2019 had also done a baseline survey of postoperative pain management. At that time, patients were asked to rate their pain on postoperative day 1 and on day of discharge. And what they found was that 28% of patients reported severe pain, 25% of patients with severe pain reported never being asked about their pain, and they found that pain scores were highest for orthopedic surgical patients. So their initial goal was to assess pain management practices, but also to target which surgical service was most in need of improvement in the area of pain management in order to create a targeted pain management protocol. Because we felt we needed to raise awareness of what we were doing throughout the hospital, and in order to involve the nurses in this process, we held a condensed essential pain management workshop for 164 of our nurses, which was the majority of our nurses, in the tools utilized in this workshop. So based on our findings, because we identified the orthopedic surgery service as having the highest postoperative pain scores and therefore most in need of implementation of a pain management protocol, we created this protocol which included interventions for the time of admission, intraoperatively, and also postoperatively. This protocol was created with significant input and feedback from the orthopedic surgeons in collaboration with the anesthesia team. We also created a laminated card, which we wrote the protocol on, which was distributed to each of our orthopedic residents so that they could carry it with them in their lab coat pockets and refer to it when writing orders. We also provided all the nurses who attended our training with a laminated pain scale that they could carry with them. So moving forward, we're currently auditing the practices of our orthopedic team to see how this protocol has changed their prescribing and documenting practices. We plan in the coming months to repeat the initial audit done in 2019 in order to compare pain scores before and after this intervention. So in conclusion, we found that a systematic assessment of postoperative pain management at rural hospitals in Burundi and Kenya identified outcome and process measures in need of improvement. This enabled targeted and context-appropriate implementation of a postoperative pain protocol. And this protocol was accompanied by training of physicians and nurses to address process deficiencies related to pain assessment. On behalf of our teams in Burundi and Kenya, I'd just like to say Murakoze cyane na asante ni sana. Thank you very much.